we did actually one of the first trials in large cell lymphoma in patients who were already had a transplant. We had an international trial of 72 patients who got pitolizumab, which is probably one of the first checkpoint inhibitors. Turns out it may not work like a checkpoint inhibitor, so it's kind of in the background now. But we certainly saw very little toxicity with that drug. I think the question is, what's going to be the role of these checkpoint inhibitors when you try and begin to combine them with other more standard treatments? How do you combine what we know works with one of these drugs that may or may not work? And so that's the purpose of the trials Dr. Winter is running. There are some data from the Boston group suggesting that there is some added toxicity if you do a checkpoint inhibitor and then have to do an allogeneic stem cell transplant. We're going to address this somewhat. There's a trial coming up with a combination of Celgene and Juno, called the platform study, which is going to be combining the Celgene checkpoint inhibitor, durvalumab, with CAR T cells in patients with diffuse large B-cell lymphoma. So it certainly makes sense that you begin to combine the checkpoint inhibitors with CAR T cells, but the safety issues and how to work it, and what the doses, what the sequencing should be, still needs to be worked out. And that's going to be the future of some of those trials. So I think there's a place, but we have to sort of be careful about integrating it to existing therapies.